All right, my name is Matt Pyle, and today we're going to be talking about ocular ultrasound. So why ultrasound the eye? A few reasons. The sort of traditional way of visualizing the back of the eye that you've learned about is direct fundoscopy. You learned about it in medical school, and you basically never do it again. It requires that you dilate the eye, which is not something we usually have time for in the emergency department. And if you don't dilate the eye, it's not a very good test, and it misses a lot of ocular pathology. And it's just not really something that's in the scope of emergency medicine. The other reason is that a lot of these pathologies and really any serious ocular pathology is something that's going to be managed by a consultant. And consultants are always easier to motivate, especially in the middle of the night, if you have some definitive proof of your diagnosis rather than just a strong clinical suspicion. And finally, the eye is an excellent structure to ultrasound because anatomically it's very easy to ultrasound. It's very superficial. There's almost nothing between you and it, really just the eyelid, apart from the sort of bony ridge of the eyebrow and the cheekbone. It's a very easy structure to get a good acoustic window on, and all of the pathology looks basically exactly how you are expecting it to look. And all of the normal anatomy looks basically exactly how you learned it looks in anatomy textbooks. So it makes it a very conceptually easy ultrasound to do. So what pathology can we see on ultrasound in the eye? So retinal and vitreous detachments, those are important diagnoses to make, and they're very difficult to really confirm without an ultrasound because they are a dilated exam that, again, we don't do. Vascular issues like central retinal artery and vein occlusions you can also make on ultrasound. Lens dislocation is a very easy diagnosis to make on ultrasound. Globe rupture and foreign body we'll talk about, and we'll look at some images. There's a caveat with that one as to whether or not you really should be doing ultrasound for that, but we'll talk about that when we get there. And then papilledema or increased ICP. This is something that even if you did do a good fundoscopic exam, could be very difficult to see, and specifically in the ER where the patients where we're really worried about increased ICP are, brain bleed, altered mental status patients where a good dilated exam is not possible. Ultrasound now gives you the ability to evaluate for papilledema and increased ICP on anybody. Anybody whose eyelid can be closed, you can do this study. So anytime you do an ultrasound talk, you have to do the obligatory data that shows that we can do this ultrasound and that it correlates with the gold standard. So in this study, this is one of the first big studies for ocular ultrasound. They compared ER point of care ultrasounds to the quote gold standard of an ophthalmologic evaluation or a CT. And they found pathology in 26 of the patients, and the ultrasound agreed with the gold standard diagnosis 60 out of 61 times. So part of that is, that we're awesome and we're well trained, but part of that is what we were talking about at the start of the lecture, which honestly is that this pathology is sort of intuitive in the way it looks and is quite often fairly easy to see because the eye is such a good acoustic window. So how do we do this scan? Well, the eye is a three-dimensional structure, so you want to image it in two planes at least, so sagittal and transverse. So that's the probe marker to the patient's head and to their right. Special things about the eye in terms of settings on the machine. Ocular presets on the machine will change the energy output of the machine. So the eye is one of the tissues like the testicles, ovaries, and babies where we want as little energy in the scan as possible because these are sensitive tissues. So it's important to switch to the ocular preset if your machine has one. You're also going to want to turn up the gain. That's because a lot of the pathology that you're looking for is in the posterior chamber and is floating in anechoic fluid, and so you want to make sure the gain is quite high. These are images that tend to be overgained on purpose. And then a lot of the pathology won't be visible unless you get what's called dynamic imaging. So that's a clip of the eye while it's moving. So you hold the probe still and you have the patient look left and right and up and down, and that will move the contents of the eye and often reveals pathology that you wouldn't see otherwise. So how we actually set up for the scan, you're going to have the patient look straight ahead and close their eye, and then you need to put a tegaderm over their eyelid. And the actual technique of applying the tegaderm requires a little bit of finesse, because you want to make sure there are no air bubbles underneath the tegaderm, because if there are air bubbles, it's going to really mess with the image. And then you just put a heap of gel on top of the tegaderm. Now, the tegaderm is there to protect the patient, not really because the ultrasound gel is irritating if it gets in your eye. It's really more of an infection control barrier. And the heap of gel serves two purposes. It sort of fills the cavern created by their forehead and cheekbone, and it also helps make sure that you aren't putting too much pressure on the eye, because that can be quite uncomfortable. This is one of those studies where you almost don't even want to be making contact with the eye. You want so much gel between the probe and the eye that it's almost floating. The linear probe is the probe that you're using because it's a very superficial structure, and you're going to need very little depth to see the whole eye. So here's a picture of how that would look. A couple of things in this picture that are wrong. Number one, the person doing the scan is not wearing gloves. That's obviously not great. And number two, they aren't using the tegaderm on the eye. But apart from that, everything's great. They are using a linear probe, and you can see the copious amount of gel. So here is the anatomy drawing anatomy that you are accustomed to seeing. So here's the anterior chamber of the eye, the lens with the ciliary body, the retina, posterior or vitreous chamber, and the optic nerve here. And here's what it looks like on ultrasound. So again, you can see most of the eye is fluid filled, so it's anechoic. In the near field, closer to the probe, you have the anterior chamber. You have the lens, where the outline of the lens is visible as a hyperechoic rim with the ciliary body anchoring it to either side. And then the retina down here in the far field, posterior chamber. And here you see an example of what happens if you're a little bit heavy-handed. So that anterior chamber is now gone. Right? This person is putting too much pressure and actually squishing the anterior chamber. Now, because you're going to do this scan mostly looking at the screen and not the person, and also because their face is going to be, partially obscured by your hand in the tegaderm, this may be your only indication that you're putting too much pressure until they sort of slap your hand away from them. All right, so let's start talking about some pathology. Retinal detachment is the first pathology that we're going to talk about. So retinal detachment, clinically suspected in patients with sudden onset flashes or floaters or vision loss that's like a curtain coming down over their field of vision. We often see it with trauma, also see it spontaneously, especially in people with connective tissue disorders. So a fundoscopic exam, a dilated fundoscopic exam, is really how this diagnosis is traditionally made. But if you imagine that the fundoscopic exam is looking through a window into a big room, which is the eye, you don't necessarily see all the way to the edges. So fundoscopy isn't even a perfect test for retinal detachment. It may miss small detachments around the periphery. Ultrasound, on the other hand, has the advantage of seeing the entire posterior chamber and the entire retina. So in a lot of ways, it's better than fundoscopic exam. And so here's a picture, a video clip of a retinal detachment. So like we were talking about before, it's a very intuitive pathology. So here's the anterior chamber, right? As they fan through in the clip here, you can actually see the pupil. And then here in the posterior chamber, you see all the anechoic posterior chamber vitreous fluid. And then you see something floating in the middle here. And it's a little flap of something. And importantly, in terms of making the diagnosis of retinal detachment, you see that at one point in the clip here, these two flaps of dissection actually come together and are attached to the shadow that's behind the eye, and that's the optic nerve. And the reason I say that's important is because in a second we're going to talk about vitreous detachment, and because the retina is really just an extension of the optic nerve, all retinal detachments will not cross the midline. They will anchor at some point, either in the middle or earlier, because they have to feed down into the optic nerve. So this is a tricky retinal detachment because it's actually on both sides of the optic nerve, but because you can see that it's tethered here to the optic nerve, that's how you know that this is a retinal detachment and not a vitreous detachment. Here you have another retinal detachment. This is to demonstrate the importance of these dynamic images, right? So the person is looking off the side here. You can see their anterior chamber and their lens. This is the retina. Here's the optic nerve. And as they look left and right, you can see this retinal detachment more clearly as it sort of flops around in the vitreous chamber. Here's a more subtle example. Again, anterior chamber here, and the retinal detachment almost invisible there until they start moving their eye back and forth. Now, the one exception to the rule that the retinal detachment is going to anchor to the optic nerve would be a MAC off retinal detachment where the whole thing, including the macula, has been removed. And the reason that's not going to be hard diagnosis to make clinically is they will be completely blind in that eye. It won't be a curtain coming down. They will just have no visual acuity in that eye. And so this retinal detachment, you can see, is anchored, doesn't cross the midline. It attaches to the optic nerve right there. So here's another thing that you'll often see with retinal detachment. So again, anterior chamber and lens. And in the posterior chamber here, we see this little flap. You see this hyperechoic mixed echogenicity, basically gray stuff between the retina and the back of the eye, and it looks an awful lot like clotted blood that you've seen in other images because that's what it is. So that's a retinal detachment with hemorrhage underneath the detachment. And this is what that would look like on fundoscopy. The second pathology we're going to talk about is vitreous hemorrhage. So that's similar to retinal detachment. Instead of the retina detaching, it's the vitreous, which is the layer just inside the retina, often associated with bleeding because it's a very vascular structure. You see it most commonly in the elderly. Can also be traumatic, can be spontaneous, especially in people who are nearsighted. Again, it's a fundoscopic exam, the loss of the red light reflex and the inability to directly visualize the fundus. But on ultrasound, again, it's a little more obvious what you're looking at. So here is a vitreous hemorrhage. And so you can see that it's a lot less organized than the retinal detachment, right? Anterior chamber here, retina's down here, and instead of one clean flap floating back and forth, you have all this debris basically in the posterior chamber, which up until now, all the examples you've seen were just pure black fluid. Here's another example that illustrates again the importance of those dynamic images. So as they look back and forth, you can see something swirling around in the posterior chamber, and unlike the retinal detachment, you can tell that it isn't anchored at any point, right? There's the optic nerve going back and forth, and this detachment inside the eye is untethered. It's just flopping around. Foreign body is another pathology that we're going to talk about. So you will notice that this is a much lower quality image, that it is not from GW. And the reason for that is that you should never really be doing ultrasound for foreign body for a couple of reasons. First of all, if there's a foreign body, now this is foreign body inside the globe. This isn't foreign body on the outside of the eye. If there's a foreign body inside the globe, by definition, that means that there is a hole in the eye, and that is a ruptured globe. And we don't want to ultrasound ruptured globes because, number one, it's a very high risk of infection, and you don't want to be the reason this person got endophthalmitis if they didn't already have it. Number two, we don't have a replacement for aqueous and vitreous humor, and so any pressure that you put on the eye while there's a hole in it is going to remove some of that fluid, and that's not great. Now, if you were to accidentally ultrasound someone for a foreign body, this would basically be what you were looking for. So in the anechoic posterior chamber of the eye, a bright white linear structure, same as a foreign body anywhere else. Here's another example, and you can see the artifact behind what is presumably a metal or glass foreign body in the globe here. And if you weren't completely sure what you were seeing was a foreign body, you were really hoping that it wasn't, because you're embarrassed that you started to do an ultrasound on an eye and realize there's a foreign body, and you're trying to prove that it's not, you can turn on color phones. So really, this is here to illustrate a point that because of the way a color signal is generated by the ultrasound machine, foreign bodies will have this sort of sparkly color appearance around them. That's not because there's actual flow there, it's just the way the signal kind of bounces off of the rough edges of a foreign body. And so some kidney stones will have this appearance, but jagged metal and glass foreign bodies will also have it. So globe rupture, another one of the true ophthalmologic emergencies that we deal with. Again, a high risk of infection and a loss of the vitreous and aqueous humors, which is not good. They cannot be replaced. The clinical suspicion has to be there from the mechanism, so that's direct trauma to the eye, especially high velocity foreign bodies like metal shavings. A slit lamp exam with fluorescein will reveal something called Seidel's sign, which is fluid leaking out of the eye, and you can see it as a sort of waterfall effect in the fluorescein. You may also be able to make the diagnosis on CT or fundoscopy. Ultrasound, which again you shouldn't be doing intentionally, but does have some findings. If you were doing ultrasound for globe rupture, you would have to be doing it very carefully, and you would have to be doing it in a situation where you were making a decision about transfer to definitive ophthalmologic treatment. But even then, I would say it's a pretty dicey thing to be doing. If you're going to be doing it, obviously the goal is as little pressure on the eye as possible and absolute sterile precautions. And what you would see, again, sort of intuitive pathology, is the anterior chamber looking flat, even with no pressure from your hand. That's because that fluid has leaked out. And you may also start to see some folding and deformity of the eye. So the vascular emergencies of the eye now, central retinal artery and vein occlusions. So arterial occlusion is painless, it's sudden, and on fundoscopy you've learned about the cherry red spot on a pale retina. The treatment for that, manual compression of the eye to try and dislodge the clot and move it as distal as possible, acetazolamide to lower the pressure and improve perfusion, and then sometimes thrombolytics. Central retinal vein occlusion can also be sudden painless vision loss, or it can be more gradual. On fundoscopy, it's the blood and thunder, much angrier looking retina with dilated veins and hemorrhage. The treatment's a little complicated, but involves lowering the intraocular pressure again to improve perfusion. steroids and photocoagulation, ultimately, obviously done in consultation with ophthalmology. Now, before you even look at the images of what this pathology looks like, you can probably guess how ultrasound is helpful in making this diagnosis, because we showed you how to see the optic nerve, and if the central retinal artery and vein are right there, then the easiest way to find blood flow on an ultrasound machine is to use color flow. So in this image, you put the color flow box behind the posterior chamber, right? So this is the optic nerve, and you can see blood vessels. Some of them pulsatile, like these two. Some of them with a constant, steady flow of blood. So the pulsatile one's obviously the artery, and the constant, steady flow is the vein. You can also use Doppler. Right? Here's the pulsatile flow of an artery and the continuous flow of a vein. The absence of color in that area, or the absence of a Dopplerable signal, would be what you were looking for in a central retinal artery or vein occlusion. Lens dislocation is another very intuitive pathology. So the hyperechoic oval-shaped lens now, instead of being in the anterior chamber, is in the posterior chamber. Dislocations will almost always be posterior, and on dynamic imaging you can see it sort of sliding back and forth. This is not really pathology, but it is an abnormal thing that we often see. So now you will see that the lens, instead of being that sort of predictable oval shape, is a perfectly straight, thin, hyperechoic line. And that is what artificial lenses look like. Now we come to elevated intracranial pressure. Now, measuring intracranial pressure directly in the ER, we basically only have one way of doing that ourselves, and that's with an LP and getting an opening pressure. And the problem with that is a one-time measurement. That is not a continuous monitor, which means that if you're doing things to lower the intracranial pressure, you can't track the effect of your treatment or the worsening of the patient's condition. In order to do that, you need a bolt or a direct monitor, a direct intracranial pressure monitor, and that needs to be placed by neurosurgery. Neurosurgeons are not available everywhere, and they are not available immediately in the emergency department in most places. So when they did this study and realized that there were ultrasonographic findings that correlated with patients who had increased intracranial pressure, it was very exciting. This was a very useful thing to have in especially austere locations, where you are more likely to have an ultrasound machine than a neurosurgeon. So the principle behind ultrasound measurements in elevated intracranial pressure is that if you imagine the increased intracranial pressure really only has two places that it can go. It can go down your spinal cord or out through your retinal optic nerves out to your retinas. And so increased intracranial pressure would cause edema and swelling of the optic nerves as the pressure sort of popped out through your eyeballs, and that edema could be measured as an increased diameter of the optic nerve. So this slide is being weird for some reason when I record the audio, so there's going to be some repeated points between this slide and the next slide, but this is what a normal optic nerve looks like. So in the posterior chamber, you have this shadow going down from the retina, and this is the optic nerve. But the first thing to know is that that isn't technically the optic nerve. That is really an artifact created by the optic nerve, and that means that some of the measurements can be a little unreliable. So this is how we would measure an optic nerve. So this is a normal optic nerve. This is the posterior chamber. This is the retina, and this is the optic nerve coming down from it. It appears as a black line. It's a shadow. It's really an artifact created by the optic nerve. isn't truly the optic nerve sheath, so that measurement can be subject to some artifact, and that may make it a little inaccurate. But what you do is, starting from the retina, you go 3 millimeters back, and then you measure perpendicular to that line the width of the retina. And what they found in that first study, and have corroborated with, validated with several other studies, is that anything over 5 millimeters corresponds with increased intracranial pressure. So here, 3 millimeters back from the retina, and they measure the width, and the diameter here is just over 5 millimeters, so slightly abnormal. So you're probably thinking, well, I'm very good at fundoscopy and finding papilledema, and why would I even need to use ultrasound for increased intracranial pressure? And so remember, if you go back to the pathophysiology of why this measurement works, the increased intracranial pressure causing edema in the optic nerve, it would make sense that that edema would happen before you even saw papilledema, right? Because that edema has to travel down the length of the optic nerve as the pressure increases before the optic nerve can bulge at the disc and be visible as papilledema. It also makes sense, as this study showed, that you would be able to measure papilledema on ultrasound. And so they looked at people whose optic discs bulged by 0.6 millimeters and found that that correlated well with fundoscopic exams for papilledema. And so this is what that would look like. So again, in the posterior chamber, you have the retina, you have the optic nerve here, and you have this tiny little mountain at the site of the optic nerve, and that's papilledema. And you can see how that's much easier to visualize than on fundoscopic exam. All right, so the take-home points: ocular ultrasound is easy, the pathology is intuitive, so it is a reliable and effective study to do. A lot of these pathologies are very difficult for you to diagnose otherwise. So use it whenever you have a clinical suspicion for one of these things, but use it with caution in the traumatic eye. If you have a suspicion for globe rupture or foreign body, I would say just don't do it. If you have any questions, you can direct them to Kat, or feel free to email.